Hi, we're back with the final session of our first NCLEX Coach mini sessions. This is so fun. Like, seriously, I'm feeling this. Now, so when we look at our EKG, we found our P wave and we're trying to figure everything out. Let me just say something about the P wave, because I'm not just about reading a strip. Any tech can do that. You're a nurse, baby. You're a nurse. You really got to know why things are happening. So if there's a pause after the P wave and there is heart block, which is true, it's going to be heart block. Sometimes it's a pause. Sometimes it's not just this long pause, but it actually skipped a QRS, whatever. Here's the deal. If there is no P wave at all, like none, oh, that's a big deal, because P waves are atrial activity. Remember the flow of blood through the heart? You've got to go through the right atrium, you got to go through the tricuspid to the right ventricle. Well, in the atrium is where the heart is filling up with blood. It's chilling and filling, you know, like at the club. And so the atria of the heart are chilling and filling with blood, and it should be pretty much at rest. Well, when the atria contract, that's how we get a P wave. So if we don't have any P wave, then we don't have any atrial contraction, and you should be thinking, aha, AFib or A-flutter, okay? Now, let's go into our heart block, because I think heart block is pretty simple for students if you just roll with your girl. So I'm gonna come in a little closer. We're kind of like amateur with this video thing, so just hook us up with like patience, okay? Here I come. I'm coming. Aaron, are you ready? We're doing this shit. Got it? Okay, elbow to elbow. Let's make sure we can see this P wave. Are you all in on that top strip, dude?
Got it.
All right, there we go. Listen, students, here we go. This is your predictable P wave. Go down. This is your predictable P wave. If you look at this P wave, it's right up against the QRS. This P wave, late to the party. Look at that gap. Let's go a little bit further. P, Q, R, S, T. There's another P. Look at that long pause. No pause, pause, longer pause. Oh, shit. Then we did something really weird. P wave, Q, R, S, T, hooked up a P right next to that. Didn't even have a QRS in here. Talk about a pause, that's ridiculous. Then we had a normal P wave. Why is it normal? It's right up against the QRS. Then T wave, P wave, pause. QRS, T wave, P wave, pause. QRS. That pause is longer than that pause. That pause is the first pause. This one's normal. This is heart block. The best thing you can do is look at the P wave. Look and see if it's right up against that QRS. Now, we're finishing up, but I got the hookup for you. The bottom line to who you see first, who you prioritize, who's most essential, who requires follow-up. All that shit means the same thing, by the way, is right down here. Now, Aaron, I don't know if you can see it, but I put down here the order of priority for your EKG strips. VFib is the most important. No pulse, no response. We're basically dead, and you need to hurry up. Start some CPR. You got to call your code. You got to do CPR before you get the defibrillator. Remember that, because we have no pulse, and wasn't that the protocol? Unless you walked in with defibrillation equipment into the room, typically you walk in and you're like, fuck my life, my patient's in VFib. And you just start pounding on that chest to staying alive, staying alive, staying alive, staying alive. I'm sorry, I get so wrapped up. VFib, no pulse, no response. VTAC, attack. Could have a pulse, might not have a pulse, but it's the second most deadly strip. PVCs. PVCs are ischemia. They're not getting any oxygen. If you have enough in a 6-second strip, they're just like a heart attack. troponins, oxygen, AFib, A-flutter. Oh, that's a coaching session in and of itself. Last but not quite least, but least in the list, is supraventricular tachycardia. If you let this patient continue, they're going into cardiac arrest. There you go. I'm done. We did it. Yay! Hope you learned some. Bye.